So we've got between now and just before 3 o'clock for me to talk you through as much, hopefully, practical information as I can about managing side effects from antidepressant medications. But hopefully I'll have a chunk of time at the end for questions, but it might not be a bad idea as we're going along for you to hang on to your questions, and I'll try and make sure that we have some space at the end so that we can deal with that. Now, in terms of managing side effects, but before anything else, actually she's constipated, she doesn't have a bladder infection, and he's sleepy, he doesn't have a headache, but I'll get on to the rest of them in a bit. In terms of disclosures, I don't have any conflicted interest to declare. I don't do anything other than sit in an office and talk to patients all day long. As far as an agenda for this afternoon goes, I'll be talking about some really broad brush general ideas about thinking about side effects from antidepressants, how to manage them, and then in the second part of my talk I'll go through some of the more common side effects and give you some hopefully helpful strategies and suggestions about how to manage them. Before anything, it's so important to have in the front of our minds what the goal is when it comes to treating people with antidepressant medication. If what we're dealing with is depression, the task is full remission. Leaving people with partially treated depressive symptoms has a huge impact on quality of life, and also it's one of the key risks for people dropping into a significant depression at some point in the future. So in terms of depression, the aim of the game is to eradicate the syndrome completely. If we're using antidepressants to treat anxiety states, then that's all about helping people to contain the extent of their anxiety. Because short of a general anaesthetic, you can't eradicate anxiety. It's a normal feeling. We all feel anxious from time to time. I'm feeling quite anxious at the moment. But the aim of the exercise with antidepressants and anxiety shrink the syndrome both at the smallest amount of medication that you can get away with. And the reason for that is undertreating people, like I said, drops quality of life, hikes the chance of relapse. It's quite common though for people to intentionally undertreat themselves. It's a bit like the staunch guy with a splitting headache who bravely takes half a paracetamol and then moans that paracetamol's hopeless for treating headaches. So not undertreating is important, but also not over-treating, not taking more medication that you need. The main cause for that is getting impatient and accelerating dosage increase without waiting for it to unfold. But the reason not to overtreat is that for most drugs, they have a linear relationship. The more the dose, the more the side effects. With the exception of mirtazapine, which is a curious drug, the bigger the dose, the fewer the side effects. Side effects from antidepressant medications are massively common. The STAR-D study, which was an enormous multi-centre study in the States running through the best part of 10 years, looked at side effects, and about 3/4 of people complained of some form of side effect with their first up antidepressant. But we as treaters tend to either overlook side effects or not explore them thoroughly. Patients report way more side effects than we make note of. Also, because of side effects, the compliance with antidepressant medication is notoriously poor. This is a British study where almost 50% of people weren't filling their prescription for antidepressant medication 6 months after they started treatment, primarily because of side effects. And about 1 in 5 people with antidepressants feel as though the misery that they get from side effects doesn't justify the amount of benefit that they get from the antidepressant medication. So bottom line, side effects from antidepressants are almost the rule rather than the exception. The downside of side effects, primarily is non-compliance. People don't like to take medication that makes them feel bad, especially if they're going to be using medication over a relatively lengthy period of time. The downside of non-compliance is that it extends the duration of the depression, and that tends to spill off other problems. The longer the episode of depression, the more severe it tends to become for most people. The impairment that it causes, vocational impairment, social impairment, tends to increase. The burden that they create as depression intensifies tends to increase. Burden on their friends, their family, burden on their employer, burden on us as treaters tends to go up, and also the longer the illness, the higher the risk for suicide is. Also, with the non-compliance issue, it does increase the risk of recurrence, and that's so important to be aware of. Treating depression is a two-target approach. The first target, treating depression, is to get rid of this episode of depression. The next target is to make sure that this is the last episode of depression, doing what we can to prevent recurrence, because depression's an accumulating risk problem. Your one-off chance of getting depressed in New Zealand is about 20%, but if you've had one episode of depression, your chance of getting a second goes up to about 50%. If you've had two, the chance of a third goes up to about 70%, and it goes onwards and upwards. The depressive episodes tend to get longer with recurrences, they tend to be more severe, and the episodes of wellness between episodes tends to shrink right down. So the aim of the game is to treat effectively, and in order to treat effectively, we need to be giving people medication that they can actually tolerate. The other downside, substantial downside of medication side effects is they can have an enormously adverse effect on the doctor-patient relationship. If people get side effects, particularly side effects that they're not aware that they're going to get, it hits trust, it hits confidence. It's so common for people to lose hope, and hope is so important to have to make a recovery from depression. Trying to make a recovery from a long-term miserable depression without a sense of hope is a very uphill battle. Hope impacts willingness to keep on going, and depression is oftentimes a difficult thing to treat. Only 1 in 3 people are going to come fully right on their first antidepressant. It often is a process of being prepared to try various options. You need to have the perseverance and the tenacity to keep going, which is difficult if they're making you feel really unwell. In terms of prescribing, how you make your prescribing choices, in mental health, it's very much a conundrum between art and science. There's very, very little that we can use to predict which pill is going to be effective for which patient without causing them difficult side effects. And oftentimes for me, and I'm very happy talking to patients about it, I think it's a combination of educated guesswork and luck to get the right antidepressant. People need to be aware that the pill that you're giving them has a reasonable chance of getting them well, and not overblow how effective the medication's going to be, but also help them to know that if this particular one doesn't crack the problem, then there are plenty of other options to be going on with. Prescribing is, and we'll all know this, it's very much like going down a decision tree. The first part of the process of prescribing is the cardinal rule of ethics, don't cause harm. Generally, with a depression presentation, the first branch in the tree is don't do anything if it's likely to go away by itself, or make an intervention of some sort. And with depression, there are a whole raft of interventions. We can think about lifestyle interventions, helping people with exercise, giving them some dietary advice, balance work and fun, look after sleep, build up some skills to manage depression. But obviously medication is an option, particularly in the group of people with moderate to severe depression, because it's very difficult with a moderate to severe depression to think your way out of the problems. Pills are helpful in moderate to severe depression by shrinking the extent of the depression, getting you from the deep end of the pool into the shallower end, and then it's all around lifestyle and tools to help get out of the pool and make sure that people don't drop back in again. If we're thinking about medication all the time, and this isn't obviously true just for psychotropics, it's a balancing act between something that's tolerable enough and effective enough. At the very end of last year, in December, the Australia and New Zealand College put out their guidelines for managing mood disorders, and within that they included a table that came from pooling a huge number of psychiatrists about their experience of antidepressants in terms of effectiveness and tolerability, and came up with this cool little graph that looks at how effective things are, how tolerable they are. The SSRI is most people's first choice. See how anxious I am? It's terrible, I won't do that anymore. SSRIs are quite effective, quite tolerable, and then it goes through the other options, the sedating antidepressant mirtazapine, relatively effective. The NDRI, a noradrenaline-specific antidepressant called reboxetine, which we can't get here, that's a massive overestimate. Reboxetine has a very, very low impact in terms of effectiveness. The ones that carry the biggest punch, tricyclics and the classical MAOIs, also have the biggest punch in terms of side effects. What makes for side effects? It's all about specificity. If we're able to design a pill that hits the bullseye, it's unlikely to cause side effects, and hits the bullseye in terms of the neurotransmitter system we're after, possibly even specific enough to pick out a particular receptor, possibly even to pick out a particular area in the brain. If it's depression, probably it's got something to do with the ventromedial prefrontal cortex. But the more of a shotgun, the more you scatter outside of the bullseye, the more likely it is that you're going to get side effects. So if you hit other monoamines or other sites, or if you start to hit other neurotransmitter systems completely, blocking histamine, anticholinergics, that's when side effects start to come into the mix. How do you make your decision between different pills on the basis of tolerability and effectiveness? I try and make it as collaborative as I can, talking with people about the various options, what might be a good fit for them. If what we're dealing with is, let's say, a first-up episode of clearly diagnosed depression, and we're putting up against it a relatively effective antidepressant with a relatively tolerable profile of side effects, generally that's a no-brainer. That's something that we're likely to be comfortable in thinking about. At the other end of the spectrum, if we're dealing with a really mild depression, we probably wouldn't think of putting up against that in a high potency option with loads of side effects, if that makes sense. In between, there are people with really difficult to treat depressions, multiple episodes of severe depression. In that sort of situation, we might want to think about using a high potency option, even if it has lots of interactions, lots of side effects. And then there's the tricky group, the people with mild depression. What about a mild antidepressant like moclobemide? Largely that's a matter of patient choice, I think. Bear in mind that people will respond positively to an inert substance, but there's also this thing called the Nocebo Effect, where people develop side effects to an inert substance, a placebo. Nocebo complaints are really common with depression. If you look across loads of randomized control studies, more than 10% of people report side effects to the placebo. And the group of people, you can predict the group of people who are more likely to get side effects from placebos, and you'll probably recognise this sort of thing in your practice. You're more likely to develop a side effect if you expect it. If you expect that you're going to get a headache, you go looking for it and you find it. So if previously you've had side effects of pills, it's likely that you'll notice them. If family or friends tell you about their side effects, the internet is an enormous double-edged sword. So many people, and I think sensibly, will go online and they'll Google their pills, but they'll see an enormous list of potential side effects. Not uncommonly, people start to look for them and find them. Also, the group who are predisposed to notice their distress in terms of their physical symptoms, who somatise, are more likely to pick up side effects from placebos. Another general point is the timeline that we can expect in terms of antidepressants. This is a graph that I run through with almost everybody that I prescribe for. If we're looking at weeks ticking along the bottom, side effects tend to emerge reasonably quickly. Within the first day or two or three, they tend to reach a peak, and then for most people they start to wear out after 2 or 3 weeks. In terms of benefit, there's a lag. Most antidepressants won't do anything at all until you've been taking them for 6 or 7 days, and then if you're lucky, it's a slow progressive improvement that doesn't plateau out until you've been taking them for 10 to 12 weeks. The challenging bit is in here where people are getting loads of side effects potentially, but they're not getting very much benefit. And that's an area where people need encouragement. They need to be advised about the possibility of side effects, that they're likely to go away. It's all about information. I used to think that if I tell my patients about the side effects that they might experience, it'll put them off and they won't want to take anything. I think much more likely, the more information that we give people about side effects, the less mysterious they become. If people are prepared to accept that they might get, for instance, a dry mouth, and this is what they can do about the side effects, then it tends to make people that much more accepting of what's going on. Just on that point, even though tricyclic antidepressants have a big profile of side effects, they're really predictable. And a group of people benefit from that. For instance, the SSRIs, their side effects are a lot more hit and miss. They're a lot harder to predict. And if you're using something, an antidepressant, to treat a problem in a patient who's really likely to notice a side effect and worry about it, for instance, people with panic disorder, if you can let them know really clearly that they're likely to get a dry mouth, constipation, dizzy when they stand up, and this is what you do to manage it, it can make it easier for people to make their way onto those sorts of medications. Mimics. Symptoms of depression and anxiety so commonly overlap side effects of medication. And the list of the similarities is long. You know, with anxiety, it's common to get tremor. Some SSRI antidepressants as a side effect will cause tremor. It's very difficult to know what you're dealing with a complaint. Is this a symptom of the illness, or is this a side effect of the medication? And it gets particularly difficult if you're changing antidepressants, because some antidepressants have a withdrawal syndrome. So if you're meeting with your patient who's complaining of a physical symptom, it's so hard to know, is this the illness, is it the withdrawal from the old drug, is it side effects from the new drug? What can we do to try and tease that out so that we know what we're dealing with? First up, the timeline's important. If the problem preceded the antidepressant, it was probably a symptom of the illness. But also it's useful to change the dose of the medication. By that I mean if you increase the dose of the antidepressant and the problem that the person's talking about gets less bothersome, it was probably a symptom of the illness. If you increase the dose and that problem increases, it was probably a side effect. Flip side, if you drop the dose and things get worse, it was probably the illness. If you drop the dose, things get better. It was probably the antidepressant. I hope that's not too confusing, but that's something that I run through with people very, very commonly. Just very quickly, a common cause of confusion in terms of side effects is the chicken and egg that anxiety creates. By that I mean symptoms of illness, depression, anxiety. We make a decision to medicate. The medication causes side effects. People very often get anxious about the side effects, and they get the physiological symptoms of being anxious, which then encourages more medication, more anxiety, more symptoms, and onwards. Before talking about specific ways of managing side effects, what do we do when we hit side effects with patients? Do we give them an antidote? Do we switch? Or we just encourage people to push on with them? Got to be careful about a domino effect. By that, you've got a patient with anxiousness, you prescribe an SSRI for them, the SSRI causes a tremor, you give them a beta blocker to combat the tremor, their asthma gets worse, you give them Ventolin to treat that, that makes a tremor, that makes the anxiousness worse, and you wind up giving people medications to treat the side effects of the medications that you gave them, and the whole thing just becomes messy and confusing. Generally, for me, I make the decision about what to do based on severity. If people are really struggling with severe side effects that don't fade with time, then I'll switch them onto something different. If side effects are more manageable, I'll either get them to press on in the hope of fading away, or I'll use some form of antidote, which I'll talk about a bit later on. It's easy to assume that patients hate side effects and they want to be off medication, off that medication, which is very common. But equally, it's not uncommon for people to hold on to medication, even if it causes side effects, because they get so much benefit from it. And an example of that is prescribing clomipramine in obsessive compulsive disorder. Clomipramine is a dirty drug. A lot of people get side effects from clomipramine, but it's a relatively effective drug. And for that reason, dropout from clomipramine for OCD is surprisingly small. With side effects, it's so important to expect the unexpected. You know, it's not that uncommon for people to come up with side effects that just don't make physiological sense. People who get hypertensive from a tricyclic, for instance. But we have to take these things at face value, accept the patient's experience, try and understand it. What I get quite commonly in my practice is people coming back for a first follow-up telling me that the antidepressants made them more depressed. That's quite common, and it kind of doesn't make logical sense to me. I think that the most likely explanation of that really common complaint is that depression gets a momentum behind it. It's a bit like a truck going down a hill, so that the depression, it's getting worse and worse. You start up a pill, the pill takes a while to pull the truck to a halt. It feels as though it's getting worse. It feels as though it's getting worse because the pill hasn't had a chance to really put the brakes on before the improvement occurs. And again, I'll try and talk to patients about that. It's not that the pill's making you more depressed, it's we haven't given it enough time to actually start to do its job properly. These are down to the final few general points. It's not that uncommon for people to respond to quite a low dose of medication, which is why it's important to start with a low dose and give it time, because there are slow metabolizers who develop a good blood concentration on a small dose, but also people will surprisingly develop quite significant side effects to a low dose. I guess just be aware that people are bound to surprise you in one way or another. Another point, even though we're told antidepressants are very similar one to the other, there is a lot of difference in terms of potency and side effect tolerability. One example is the difference between the original brand product of antidepressants and the generics. And while it's a bit contentious, I think there's oftentimes quite a gap, potency-wise and side effect profile-wise, between the originals and the copies. And that was most obvious quite some time ago when Cipramil shifted over to arocitalopram, which isn't, in my experience, anywhere near as potent. Likewise, brand Arapax compared to the Loxamine generic, not as potent. More recently, brand Effexor replaced by venlafaxine. I've had a lot of people relapse going from the brand to the generic. And then surprisingly, in the last 6-12 months, I've had a lot of people relapsing going from the original sort of bluey, greeny, purpley fluoxetine to the generic arofluoxetine, which is green and yellow. There is a common arrow factor to that, but that's something just to bear in mind. There's an important point about what's in the tablet, particularly for citalopram, which is a combination of two mirror molecules, an R-citalopram and an S-citalopram molecule. The R-citalopram molecule is relatively low potency, but has quite a high side effect profile. The S molecule is high potency, low side effects. So the blend tends to have less potency. The purified version, the S-citalopram without the R molecule, tends to be a little bit more potent. And just lastly, there's the issue of parents and metabolites. An example of that, the parent compound is amitriptyline. In its first pass through the liver, it's broken down to nortriptyline, which tends to have fewer side effects, more potency. Side effects themselves significantly more common in young people and old people. Older people, because with age, kidney function, liver function tends to slow down. Side effects also more common with people with medical illnesses, particularly liver disease. It's so common for people to be taking a variety of different medications, a multitude of psychotropics mixed up with non-psychiatric medications. It's easy to jump to a conclusion that a side effect's caused by an antidepressant. It just does make sense to know that a whole variety of different drugs can cause different side effects so that we can be clear about identifying what's going on. The whole side effect issue is challenging, but something that seems to be becoming more and more studied is the interaction between drugs and the generation of side effects. And I won't go into this in any great detail, but pravastatin, one of the statins, by itself doesn't impact blood glucose. Paroxetine by itself doesn't impact blood glucose, but the combination leads to a significant increase in glucose concentration. And the more that people are looking at drug-drug interactions, the more these sort of unusual side effect problems are starting to become apparent. So, on to the specific side effects. Side effects will hit any organ system. Just about any part of the body that you think about can mobilise a side effect to an antidepressant, and the list is huge. That's the first of, I think, 6 or 7 pages of side effects listed for fluoxetine. I'm not going to go through anywhere near that. I'll just pick out the ones that are a little bit more common in my practice. The most important thing in terms of managing side effects is to wait. Give them enough time. Don't get impatient. Give people the time that they need for the side effects to fade away. That's really the most important take-home. Give people time to adjust to antidepressants. That's a very unusual photo of me happy. There are psychiatric adverse effects of antidepressant medications, which sounds a bit curious. About 15% of people with an antidepressant, their mood will go up too high. It's not uncommon, particularly for the activating antidepressants, to cause a degree of initial anxiousness or agitation, which is why some people will co-prescribe a benzodiazepine for the first week or 2. It's common for people to complain that antidepressants makes them feel dull and flat. There are a few reasons for that. It could be that they're not taking a sufficient dose of medication to treat their depression adequately, and they're experiencing some residual depressive symptoms. Very commonly, depression causes people to become less active. They wind their lives down. The less they do, the better they feel. And oftentimes that flatness comes because people aren't doing the things they need to do to feel happy. Again, depression can sit on top of a long-term mild depression called dysthymia. The antidepressant treats the depression, but they're left feeling mildly depressed. But lastly, there are some indicators that antidepressant medications can impact the reward system, the dopamine system in our mesolimbic tract, that can make us feel dull and flat, which is why it's not that uncommon for people to add in an antidepressant that increases dopamine, which is bupropion Zyban. And there's the risk, as we know, with younger people that antidepressants might provoke suicidal thoughts or behaviour. Just going through some organ systems, the cardiovascular ones are largely things that people don't notice. They're things that people are unaware of that we need to look out for them. First up, arrhythmias. Some of the antidepressants will prolong the QT segment, so we have to be mindful of that because the longer QT segments can predispose to torsade de pointes, which can lead on to ventricular fibrillation. Left bundle branch block is contraindicated with some tricyclic antidepressants. So I would suggest running ECGs in people with a history of cardiac pathology or in the slightly older age group. It's been advised not to use higher doses of citalopram because of the impact on the QT segment. So for that reason, I don't go above 40 milligrams of citalopram or 20 milligrams of S-citalopram. Hypertension can be an issue with venlafaxine. It's something to be mindful of, particularly if you're using a higher end dose of venlafaxine, 225, 300 milligrams a day in the older age population. So I'd keep a close eye on blood pressure in that group. Skin, the main problem that people have is sweatiness coming from the antidepressants. A few strategies. I suggest that first thing in the morning or last thing at night, people have a shower, get themselves really dry and dust themselves off with talcum powder, wipe most of it off. Just a little thin layer of talcum powder can stop some people sweating. Bamboo sheets made out of bamboo fibre are cool and they're quite good at wicking away sweat and evaporating it quickly. They're more purchasable online, but they're wickedly expensive, whereas a white king-size sheet costs $359. That's going to put a lot of people off. If you're really stuck with something that's working really well, but people aren't comfortable with the sweating, a little dose of clonidine or one of the anticholinergics can sometimes help with the sweats. Gut, again, far and away the most common side effect across the board with antidepressants is a dry mouth. People should be advised to drink plenty of water, have water beside them at work, sleep with a glass of water beside them in bed at night time. Having something in your mouth stimulates a bit of extra saliva. Chewing gum's helpful, especially gum that's sweetened with xylitol. Xylitol increases saliva production. A lot of people grab a lemon or a lime, cut it up into wedges, put it into a snap-lock bag so that when their mouths dry up, sucking something sour and citrusy freshens up mouths a bit. There are some glycerine mouthwashes, like the Colgate product that puts a lubricating lining inside your mouth. So important, though, to tell people that if their mouths dry up even a little bit, it's really important to floss and brush regularly because dry mouth does increase the risk of tooth and gum disease. Teeth grinding, especially with the SSRIs, is quite common. People grind away at night, grind the surface off their teeth. If it's a huge problem, a nighttime benzo can be helpful, having people fitted with a mouth guard to wear at night. If it's really severe, getting Botox into the muscles that cause you to grind. Another silent problem to be mindful of is hyponatremia. Most of the antidepressants, except perhaps for mirtazapine, do have an associated risk of hyponatremia. In my practice, in the older group above 65, I routinely check UNEs every 3 months just to make sure that people aren't dropping their sodium away. In terms of the GI tract, diarrhea, oftentimes with SSRIs or venlafaxine, will catch people out. Lots of fluids, something simple like loperamide can be helpful. Constipation is much more common though. I encourage people to really work on fluids rather than fibre. The problem isn't lack of fibre, it's because their gut dehydrates. So anything that increases gut hydration will help with the constipation, which is why lactulose, the non-absorbable sugar that pulls fluid into people's guts, can be helpful. The kiwi fruit extract, flow, is very commonly used. Nausea, finally, make sure that people have antidepressants with food. If they're nauseated, if that doesn't help and they're benefiting, something like Maxilon from time to time is what I would suggest. One of the biggest and most difficult side effects from antidepressants is sexual dysfunction. The incidence of sexual dysfunction is huge. More than 3/4 of people, if they're asked, will have problematic sexual dysfunction in men and in women across any stage of the sexual cycle: reduced libido, reduced arousal, and slowed up or prevention completely of the ability to orgasm. People tend not to volunteer that information. It's super important to ask, because if we don't ask about sexual side effects, people tend not to tell us. Some situations with guys, it's actually a blessing. People with premature ejaculation, it slows things down sufficiently so that it becomes less of an issue. The offenders, the SSRIs and venlafaxine, are far and away the most likely to cause sexual dysfunction, a bit less with tricyclics. Amongst the SSRIs, the number one is paroxetine, way more sexual dysfunction from paroxetine than from the other SSRIs. But it's a complicated issue. So many things will affect sexual functioning. Antidepressants certainly can, but depression itself is a common cause of sexual dysfunction. Sexual dysfunction, a common cause of depression and anxiety, so that one bounces around. Physical illness has the same impact on sexual functioning. Drugs and alcohol can cause sexual dysfunction. The misery from sexual dysfunction can cause people to use more alcohol and drugs. Age has an impact on sexual functioning, so do relationships. Bad relationship, bad sexual function, bad sexual function, bad relationship. It's a complicated issue that we need to be mindful of, especially when these things have interactions amongst themselves. Sorry, I'm racing through this a little bit. What can we do strategy-wise to help people with sexual dysfunction if we choose to keep on with an antidepressant? Some people would advocate reducing the dose, but you do that with the possibility of relapse. A group of people will have a particular threshold to respond, and if they drop underneath that, their chance of resurgent symptoms goes up. Some people will talk about having drug holidays. Stop your medication, wait for a day or two, have some fun, then go back on it. But stopping medication abruptly, there are a cluster of antidepressants where withdrawal symptoms become very difficult to manage. Adding in one of the phosphodiesterase inhibitors, Viagra, Cialis, is not uncommonly helpful, as is adding on either bupropion, 150 milligrams in the morning, or mirtazapine, 15 milligrams at night, both of which can, for some people, reverse the sexual side effects from antidepressants. There are a couple of herbal products, ginkgo and maca root, that in a small group of people are quite helpful for sexual dysfunction, or stop the culprit and switch over to one of the options with a low risk of sexual dysfunction, bupropion, mirtazapine. Moclobemide has a very low risk of sexual dysfunction, but it's also a very low potency option. Duloxetine is Cymbalta, which is an SNRI-like effexor. It's a good option, it's potent, it has few side effects, but it's not funded. And it is expensive, but it's likely at some point to go on the fund. It's just something to have at the side of your mind as a possibility. Neurologically, headache is common, but it's common with placebo as well. Some people will get headaches from Panadol. Make sure it's not caused by anything else, but a simple analgesic is often all people need for a mild headache caused by an antidepressant. The SSRIs can make people quite twitchy and jerky, mainly at night. Usually it's more of a problem for your partner than the person with the jerks. They're benign, they tend to go away by themselves, but if they're really problematic, a nighttime benzo can be quite helpful. The SSRIs and the tricyclics can cause a mild background tremor. Again, if it's problematic, some people will use a low dose of a beta blocker, most commonly propranolol. And some of the SSRIs make people yawn. It's not yawning from tiredness, although people often think if they're yawning, they must be tired, or it's just after lunch, or it's a boring lecture. It's a form of muscle spasm. It's a little bit like a dystonia. Most people find it fades with some time. Antidepressants oftentimes can cause sleep disturbance, sleeping too little, sleeping too much. Generally, Zyban bupropion is a stimulating, activating antidepressant to take in the morning. Mirtazapine and the tricyclics are almost always sedating. People benefit from taking them at night time, either because they help sleep at night, or if they take them in the morning, they'll just feel incapacitated by sleepiness through the day. The others, about 2/3 of the others, tend to be stimulating. People do better starting them up in the morning. A smaller group, they find those antidepressants sedating, do better taking them at night time. So in my practice, if I give somebody an antidepressant in the morning and it makes them drowsy in the day, I'll move it to night time. Flip side, if I give somebody an evening dose of an antidepressant and it keeps them up, I'll move it to the morning. Some antidepressants, the serotonin-active antidepressants, will cause people to dream vividly. Not necessarily nightmares, but just colourful, vivid, memorable dreams. If it's a real problem, I'll give people a benzo for 7 to 10 nights. Or prazosin is an alpha blocker, can sometimes suppress dreams if they're really difficult for people. I think this is the last one, which is weight gain, which is a massively common problem with antidepressant medications as part of the metabolic syndrome, which includes increased girth, high triglycerides, low HDL, high blood pressure and high glucose. Provoking a metabolic syndrome is so common if we're not careful with the antidepressants, right across the board except for bupropion, which tends to be weight neutral, or people tend to drop a little bit of weight. Everything else has a reasonable risk of weight gain. If people put weight on quickly, more than 1 kilo a week, that tends to predict future problematic weight gain. So what I try and do is have people weigh themselves once a week and let me know quickly if they're putting weight on, because it's way easier to lose a little bit than try and lose a load. There are a few mechanisms of why people put weight on with the antidepressants. Sometimes it can make them thirsty, and if people use anything other than water to quench their thirst, they can run into a risk with calories. People who drink fizzy drinks, lots of fruit juice or milky drinks need to be aware that they're high carbohydrate, high calorie. Some of the antidepressants will make people feel a bit sleepy, they'll burn fewer calories, or they'll make people feel a bit calmer, so they lose that kind of agitation, anxiousness that burns calories. Some people, it just makes them hungrier. Or it stops people feeling full after an ordinary meal. And my antidepressant horror story was a man I treated with mirtazapine. He didn't come back for a few follow-ups. I saw him, I think it was 4 months down the track. He'd put on 42 kilograms because he had a craving for meat pies. He just ate pie after pie. After a while, the pies didn't fill him up, so he would get a loaf of white bread and split it down the middle and put 3 or 4 pies in it and have a sort of an enormous pie-filled roll, and that stopped filling him up, so he wound up taking a carton of pies to the local fish and chip shop and having them battered and fried. So it can be a real problem. People can develop a craving for carbs. Also, it can alter the way that people metabolize carbohydrate, bypass the metabolism and convert it into fat. Fighting weight gain is either through lifestyle, and I've only got a couple of minutes to go, hopefully, lifestyle or with some medication options. As far as lifestyle goes, and this is basic stuff, but helping people to keep their chance of weight gain down, help them to set goals with their eating which are achievable, small achievable goals. So rather than saying don't go to a restaurant, for instance, let people know that when they go to a restaurant for dinner, rather than having a plate of fries on the side, have a little salad on the side. Exercise is important. Get people to keep an exercise diary or motivate them, either by exercising with a friend or if they can afford it with a personal trainer. Encourage people to exercise. It doesn't matter what they do. The common ones are walking or getting a gym membership, but it doesn't matter what it is so long as it burns calories. So if people are bowlers or gardeners or whatever it is, whatever helps people to move is going to be useful. The process of dieting, again, motivation is hugely important. Having people keep a food log is a log of what it is that they're eating, tends to reduce the amount that people eat. Keeping in touch with people. One of the keys to successful weight loss is giving people a telephone call from time to time and ask them about how their diet's going. Some simple things. Encourage people to look at the labels of food so that they know what they're eating. Plan in advance so that they're not caught out having to buy McDonald's or a pizza for dinner. Look after your fridge and pantry so that there aren't high-calorie, high-carb things and there are some healthy options available. Watch portion size or eat from smaller plates. You know, if you eat something on, why isn't this working, on a big plate, it looks relatively small. If you eat the same amount of thing on a small plate, your eyes get tricked into thinking that you're eating more. Small, frequent meals, load up on water to fill up your tummy. In terms of what you're actually eating, eat things that make you feel full for a while. Eat protein, eat fibre. Don't eat greasy stuff. Have low GI, complicated, complex carbs rather than the fast-burning, refined carbohydrates. Watch carbs after lunchtime. A patient of mine told me a proverb from the former Yugoslavia. If you want to drop weight, eat all your breakfast yourself, share your lunch with your mates and give your dinner to your enemies. Watch fruit. A lot of people think fruit's really good for you and healthy, but it's full of sugar, which is linked to weight gain, obviously. Try and cut down fruit or eat fruit with a source of protein. There are some medications and some supplements that people can use to track weight. In the States, it's not uncommon to use a low dose of metformin, 500 milligrams a day, as a possibility to help people drop weight. Some people advocate topiramate to help suppress appetite, although topiramate makes so many people so nauseated, it's difficult to know if they're just feeling so nauseous they can't bear the thought of food. Switching to bupropion because of its low risk of weight gain. In terms of homeopathic options, ephedra and Garcinia cambogia are both partial appetite suppressants and also increase efficiency of carbohydrate metabolism. Same with green tea mixed with caffeine. Cinnamon, things with cinnamon in it's supposed to prolong gastric emptying, makes you feel fuller longer. And that's all I wanted to say. I'm sorry, I haven't left a lot of time for questions. There's 5 minutes, I think, of question time. If anyone's got any questions?
Are there any questions? If you pop your hand up so we can get a microphone to you. One up the top.
A question.
Just bupropion kept popping up.
Yeah.
Is it funded for use in depression or only for smoking cessation?
It's smoking cessation, but I've not hit any problems for anybody prescribing it as an antidepressant. It is limited funding-wise to smoking for that prescribed period of time, but I've not had any problems at all for the last 5 or 6 years prescribing bupropion for depression. I think it's a good option. Sorry, bupropion as a first choice. If what I'm dealing with is a really sluggish depression, dopey through the day, very little energy, very little motivation, I will sometimes use Zyban as a first up because a lot of people do find it gives them extra energy, motivation to get their engine going, get up and running.
Didn't it fall out of favour because of deaths in Australia when it was used for smoking cessation? And so we were using it quite frequently and then stopped. It was associated
Death is quite an adverse side effect.
Yeah, there were a number of deaths associated with it.
The thing that sticks in my mind with bupropion is a risk for lowering seizure threshold, which is across the board for antidepressant medication. The risk is a little higher with bupropion above 300 milligrams a day. So I make 300 milligrams my absolute upper limit, but I haven't heard of any warning against it because of otherwise unexplained death. Okay. Well, thank you for that, and I wouldn't want to mislead you, but as far as I'm aware, it's a safe option.
Okay, thank you. I think we'd better call the questions to a halt. So thank you for that really comprehensive coverage of the topic. And there's a small gift for you. Thank you.